Dr. Van Dyke was unable to make it due to a family obligation. So what I'll do is I'll just introduce the speakers as their talks come. Our first speaker will be Dr. Pieter D'Hooghe, who's from our host institution, Aspetar, and he's going to speak to us on posterior impingement syndrome in soccer athletes. So Pieter.
Thank you, Dr. Hunt. It works. Dear friends, ladies and gentlemen, I have the privilege of talking to you about posterior impingement in the ankle. Now, we specifically will deal with the value of the arthroscopy in that posterior impingement, and I'm happy to take the journey along with you. I'll put it a bit higher. So I have no disclosures. Does it work? All right. Can you hear me? All right. So first of all, I would like to acknowledge our senior management, Dr. Gelogli and Dr. Landreau, for the amazing effort they did to bring our ISACOS leg, ankle, and foot committee to Doha. It's been a true endeavor and a real privilege that they found the opportunity and the effort valuable to bring everybody here. So big thanks for that. We will talk about posterior arthroscopy, but the real issue is what is posterior impingement? And I'll take you along on what it is, on what we do with arthroscopy, and why we do it in these individual cases, especially tailored for the elite athletes. Now, I invite you to take a look at the FIFA data epidemiologically on the last 5 World Cups that there have been. As you know, we have had in 1998 France, Korea, Germany, South Africa, and Brazil. Now, if you look at the ankle specifically, where there were injuries during the competition of the World Cup, you see here that 17% in Germany 10 years ago of the injuries were ankle related. That was the second biggest of all the injuries there. The 4 years after, it was 12%, and it became the third biggest injury in football competition during the World Cup. Nowadays, it's the 5th. So like Dr. van der Merwe already stated, our prevention is working, but still 10% is a big deal in elite soccer. So what is posterior impingement in the ankle? It's just a conflict, a mechanical conflict, or an inflammatory conflict of the flexor hallucis longus that is impinging on the bone. That's what it's about, and it occurs mainly with repetitive hyperplantar flexion, where you get that conflict, whether it's bony or inflammatory. Now, you see on the video the apprehension test. You have a palpatory pain over the posteromedial area mainly, and you have, when you test the flexor hallucis longus in the plantar flexion position, you have that apprehension. You can have it through an osteogonum, which we call a kind of synchondrosis, and you can have it due to a hypertrophic Taylor process. We, in this area of the world, we also encounter it in the ladies wearing these high heels that is very fashionable in the area where we live here, and we call it the Louboutin disease, meaning that when you have that conflict due to that hyperplantar flexion position, you can have the same sort of pathology findings. Now, when we talk about treating posterior impingement, we talk about, before the year 2000, we talk about open surgery, where we open the skin and we go from open to close into the depth. You can kind of compare it with the development of the city of Doha. Before the year 2000, in 1980, this was the city West Bay of Doha, and now in 2013, you see the development, and probably, if you take a picture today with the helicopter, you would see it doubled already. You can call it the way the development of posterior impingement pathology treatment got alongside with that. Before the year 2000, there was a complete underdevelopment of arthroscopy, and open surgery was the gold standard. Anecdotally, there are 3 articles I found before the year 2000, but nowadays, as the most dangerous phrase in language and medicine can be, we've always done it this way. So open surgery, no, we go for closed surgery. Because we've always done it this way is probably not the way to do it. We have to give a big thanks to our good honorary member of ISACOS, Dr. Pau Golano, and of course our mentor Nick van Dijk in ankle surgery, to develop the minimal invasive strategy of treating these posterior impingement in our athletes. And the landmark paper in 2000 and in 2000 itself, the two-portal technique changed our way of thinking about it. What do we mean? This is the posterior area of the ankle, as clearly noted by Pau, where we see the neurovascular bundle on the medial side, the suralis, the Achilles tendon, and the working area where the flexor hallucis is, the peroneals, and the peroneals on the lateral side, sorry, and the medial three tendons there. So how do we position for the arthroscopy? It's quite straightforward. We put in a relaxed prone position and we mark our landmarks. Now what we want is to identify a working space, and we go medial and lateral from the Achilles tendon, and we work in this area. You will say, okay, that's a nice clear space, but of course you have some issues with the neurovascular bundle, which we will go on immediately. Now, how do we do it? The classic treatment is to identify the flexor hallucis, to identify the conflict that is there, and then cut it away, remove it, and clear up the space. That's the easy part. I invite you to take a look at the X-rays, but to make sure that you know that posterior impingement is a clinical entity. Why is that? Because if you didn't think about it clinically, you will miss it. What do I mean by that? If you take a straight lateral of the ankle, you will not see there is a conflict. If you do an oblique view, because your clinical examination identified the potential problem there, you will see that the ostrigonum can hurt on the tendon, can give that conflict. So be aware that the clinics guide you through your imaging process. Now, what does the literature say? We know that it's a safe and reliable technique. We know it facilitates the recovery and it gives less morbidity. And that was shown in the year 2000, and that is recently shown again in a paper I found in Arthroscopy 2 months ago, stating that it creates a 50% increase in AOFAS score, which is the functional score in our athlete population that we check upon. Now that's the summary. Posterior impingement creates a possibility to remove the conflict on the backside of this area, where you can see here that the tendon can have even neovascularization due to the chronic impingement that occurs there. But the real exciting story starts here. Why? Because by doing the arthroscopy here, we've seen that we can go all the way up to the tibiotalar area, posterior cartilage. We can go all the way down to the Haglund area and even to the Achilles tendon, meaning maybe we can use this technique to evolve and treating minimal invasive cases that we see on an individual basis in our football elite athletes. And suddenly this pops up. And I'll take you on a few of these cases just to identify why we think it's very valuable to start off further with this technique. Just an idea. This is a national team football player, Qatar. The national team doctor who's here will join me because we've had an amazing journey with this player. 5 weeks, he was limping, painful, fantastic evaluation clinically, X-ray normal, did a CT scan, still too much pain. After further clinical examination, 5 weeks down the road, we do an MRI and we see a massive stress fracture of the talus. We see an initial Hawkins sign showing that there's a real need for nutritional support in that talar bone. Now, what do? We put him on a non-weight bearing strategy, as the literature says. We see that the stress fracture is on the axial view and the coronal view still there, but due to, although there is a good compliance with cast, there is a development of that stress fracture. You see the diastasis is becoming bigger. So what do? We use posterior arthroscopy just to make sure that this stress fracture is stabilized, and through a posterior arthroscopy, we fix that with a compression screw, and I know the team doctor who is here will share me in the idea that we got this player back after 7 weeks, after treatment, for playing. You will say, okay, stress fracture there, never seen that, or once in a while, that's rare. No. It's not rare in the elite athlete. You know, we published this 3 months ago. Now, in January 12, 2016, so a month ago, the second biggest Premier League team for the moment writes us to say, guys, we identified this with one of our players. We are communicating, because these are individual cases. These are not high volume cases. But through communicating individually, we learn from each other, and we see that we can progress in that way. Because it's not what literature says in the recreational athlete that always works in our elite athlete. And the message is here that we are creating a network just by communicating in this fashion. And that's the real value of what we're doing here, I believe. Posterior impingement is not just an extra ostrigonum or an extra flexor who is a bit irritated in our football player. No, you can have a forced dorsiflexion in inversion, creating a lateral tubercle fracture. It's a fracture. You can see it where the posterior talotibial ligament, an excursion from that posterior deltoid ligament, just pulls off pieces of bone. This is a fracture. This creates posterior impingement. So don't think that an inversion or eversion in forced dorsiflexion just gives some minimal movement to an ostrigonum. No, it creates fractures that heal particularly difficult on the medial side. Why? Because the neurovascular bundle is there. And every time the football player kicks inside, he will have that electrical shock because of that. So it's not just a little fracture. And if you see a more chronic case, you see what we call a Sedell fracture. It even develops to a kind of calcified, fragmented area. And if you join me, you know that the neurovascular bundle is exactly here. So every time this player, and this was a 17-year-old player, kicks inside, he can't cope with the feeling for the next 2 minutes. By removing that Sedell fracture gradually through arthroscopy, you do it minimal invasive, and you get them back safe and quick. Another story which we described, you see that associated tissue damage occurs in acute ankle sprains. What does that mean? When you have a simple inversion sprain, you can have that anteroposterior translation of the talus towards the tibia, meaning that you can have bony and inflammatory signs on the back. You can have pure inflammatory signs, and you can have pure bony signs. But look with me, you see the talus coming all the way back. This is the shift that we don't want, because this creates the problem, and it continues through that problem. So it's much more than just a simple ankle sprain that occurs in our elite players. And of course, when we know that we can evaluate the backside, we know that we can evaluate the cartilage. What do we do nowadays with a posterior localized cartilage defect in the tibio-talar joint? We can identify it, the impaction. We can use all our bone marrow stimulation, debridement, cartilage repair techniques just through the same technique. So exciting, no? Not only the cartilage can be addressed. Look at this talar cyst that was apparent on the back. We identify the cartilage lesion, we put our probe into that lesion, and we drill underneath. We identify the area where the cyst is, and we fill it up with bone, all through that posterior arthroscopy technique. So thanks to the years 2000, we've really developed. And now it's even more exciting. When you have a player that has these continuous subluxations and luxations of the peroneal tendons, he had a flat surface. We recreated with arthroscopy, and we use that posterior arthroscopy to make the groove, make it smooth, and keep it stable inside. Another idea, when we go from cartilage to the posterior area all the way to the back, we have here retrocalcaneal bursitis. When it's too much chronic, that we can really debride it, recreate a healthy environment, and make it heal in a very minimal way. We even go now to the Achilles tendon. We know that if you have a non-nodular tendinopathy of the Achilles tendon, we know that a big reason is the plantaris adhering in a bad way to the Achilles tendon. If you remove these adhesions and denervate the area, and sometimes even remove the plantaris in that area, you remove the pain and the progression towards nodular tendinopathy. There we go. An interesting story I would like to share with you is the following. We got a referral for an athlete to have posterior arthroscopy for an ostrigonum with significant inflammation around. Clear case. We also saw that there was some subtalar irritation, and we thought, that's strange. He's 22 years old, he has no previous trauma. Why is that there? Is it maybe something else? Of course it is. You see here, when you do the CT scan, you see it's an osteoid osteoma. And if you look at the posterior arthroscopy developed, it's full of depomedrol, of cortisone injections, because just to keep in play. But what is the real reason? It's the central nidus of the osteotostioma in a particular area and difficult to reach in the ankle joint, but not if you do it with posterior arthroscopy. Why is that? Well, look with me. You see on the video here, the nidus, central nidus that we palpate and we remove. By just accessing it, minimal invasive, through that posterior arthroscopy, you remove the nidus, meaning you remove the pain, and you don't have to focus on other things, because that's the real problem, not just the ostrigonum. And that's another value of the posterior arthroscopy. Of course, our football players, they play about 4 hours per day. It's okay. They play about 4 hours per day, but after that, they have specific hobbies. Specific hobbies, meaning gyrocopter, for example. What is a gyrocopter? It goes 200 per hour. It's a fantastic hobby. They love it. The only problem is you have to stop it. You have to land. Now, if you land, you have talar fractures. You use the posterior arthroscopy to put the screws in, make it heal, and then put the screws out again through the same arthroscopy. Okay, anyway. Another story. What's the value of doing fluoroscopy in posterior arthroscopy? Sometimes you have these really big posterior bony lesions. You cut them in little pieces to remove it through limited portals, because you can't remove it in the immediate position. And this patient was referred to us because he kept having posterior ankle pain. And we thought, why? He was operated, and it was done in an incredible center. But sometimes, by removing it through the portal, some pieces got stuck into the subcutaneous area. And that's what happened here. They cut it in pieces, but some piece kept there. So do with your arthroscopy, just do a fluoroscopy that you're sure that all the pieces are out. Because if you don't remove it, the pain is, of course, not gone. Another value. And of course, when you do live surgery, from an anterior impingement, this is an interesting story. Look what happens. There is a bone marrow stimulation from the anterior part, and suddenly the microfracture breaks. What to do? Well, I'd show you what happens. The surgeon is having a traction and is trying to remove that piece. And suddenly what happens from the anterior part, it flips out. What to do? So it flips out. What to do? Suddenly the piece is out. If you look, now on the back side, you see that piece here. But we started anterior. What do we do? What do we do? We just are able to do the posterior arthroscopy, take it out, and with minimal invasive strategy, you remove it. So what is the value of posterior arthroscopy? It's much more than just the tendon or the bone. It's really the whole package. And it allows you to do more and more minimal invasive techniques on the pathology there. Another story. You have normally a muscle that stops here, and then the tendon runs. But sometimes the muscle stops into the joint. Like you can see here, you can easily release it and make sure it's going the good way. A last story I would like to tell you is a coalition in a 31-year-old recreational football player. You see there's a coalition. Suddenly he can't play anymore. Or you see a really destruction of that posterior subtalar joint. Now you can do three things. You can say stop playing football. You can say wear special shoes. But these are the shoes that we normally use in hot weather, so that's difficult. Or you do posterior arthroscopy. You denudate that posterior facet, make some drill holes, make sure you reach the whole coalition and clear it, and then fix it. And then this is how it looks like. You put a screw in, a second one, make sure you're in good position, and after 5 weeks, you see already the coalition gone, and you see good healing of that posterior facet. You can extrapolate that technique towards the tibiotalar area, and make sure we develop that technique now further in the future. Of course, this is at the end of the career of the football player. This is not during the active career. So I would just like to recognize our amazing physiotherapy department, who has been not only innovative, but also very helpful in developing our ankle and foot pathology. And I hope we have some time to share further on this, but it's been a nice endeavor and journey so far. And I put some names on, I'm sure I forgot some, but at least to thank the specific ankle unit for all their amazing help. Thank you very much.